Hello. Today I'm going to see case number 2, Mr. P. He's a 55-year-old man who just had his gallbladder removed. He was having pain after eating that radiated into his right shoulder and his back. He had gallbladder stones or gallstones. So he had surgery, and then he's on a PCA pump now, and that's how he gets morphine. He also has a JP drain in his abdomen, and he's wearing compression stockings. And before the surgery, he was getting short of breath with minimal exertion, so we have to be careful of that. He has pain in the abdominal region with movement and coughing. That's about a 4. No cough, no sputum, or no wheezes. His medications are captopril, simvastatin, metformin, formoterol, and albuterol. He has obesity, hypertension, hypercholesterolemia, arthritis in both knees, asthma, and obstructive sleep apnea, which he uses a CPAP. His total cholesterol is 240, and then HDL 35, LDL 160, and triglycerides at 250. Alright, so when I walk in the room, the patient is slumped in bed. He hasn't been out of bed yet, but before surgery he had short of breath, so I'd expect that. And then all of his medications have side effect of cough, so I actually would expect a cough, but document says that he doesn't have a cough with no sputum or no wheezing, but that might be because of his Symbicort and albuterol. Those are bronchodilators, so his airways are dilated. But I'm going to do a systems review. Going to do pulse ox, and going to take blood pressure, and these were previously cleaned. (120/80). 99% oxygen. I'm going to take heart rate. And I took that for 30 seconds. I got 76 beats per minute. Right now I'm going to take respiratory rate, just watching her chest fall and rise. I do that for 30 seconds. I might expect decreased expansion and contraction of the chest wall because of the asthma. And then I'm going to also do an intake screen where I'm going to check the JP drain, and I might expect some swelling in the extremities just because of the hypercholesteremia and from not getting out of bed since the surgery. And the JP drain will be over on this side, and that's what I'll check. That is clean and dry. And there was no swelling. Oh, I'll do the test of sensation. I don't expect there to be any problems, but just to be sure. So I'm going to put this on your cheek, and I want you to tell me if it feels same or different from where I'm putting it on the other parts of your skin. Okay? Same. And I would switch cotton balls. Same. Okay, from just being out of surgery with the MSK screen, I would expect some weakness, and the bilateral knee osteoarthritis, I might expect some weakness in that area as well. Can I have you raise both arms up? There we go. And then bring that one down. Okay, don't let me move you. Don't let me move you. And yeah, let's do that. Curl up, and don't let me pull you out of this position. Can you grip my fingers? I did notice some weakness on this left side. And this side, the drain is on, so I'm just going to be mindful of that. Don't let me move you. And you can bend. Don't let me move you. And then can you squeeze my fingers? Good. You slide your heel to your butt. Okay, don't let me pull. Hurts. Oh, okay. Don't let me pull your knee out. Good. And don't let me push it in. Good. Can you bring your knee to your chest? Good. And you can relax. Bring your toe up to your nose. Good. Don't let me pull it out. Can you point your toes? Don't let me push you out of that position. We're going to do the same thing on the other side. Can you bring your heel to your butt? And can you bring your knee to your chest? Good. Relax. Don't let me pull you out of this position. Good. Don't let me push you. Good. Knee to your chest. Don't let me pull you out. Good. Yeah. Don't let me push you out of this position. You point your toe. Don't let me push you out of this position. Good. I'm going to take your sheet away. All right, because of the asthma and the sleep apnea, obstructive sleep apnea, I would like to listen to the lungs. So I'm going to get the patient to seated and we're going to listen to the lungs. All right, I already have consent from the patient to move around on her shirt and move the breast tissue when we get to that point. And yep, she gave me consent, so I'm just going to go ahead and do the screening. And breathe in and out through the mouth. All right, now I'm going to do the bibasilar. So I might expect to hear wheezing with that. I know the document says that there was no wheezing, no coughing, no sputum, but with the patient's comorbidities I've already listed, I would expect wheezing with them. But the bronchodilators might be working, so there isn't a wheeze. Now we're going to move into observation. I already observed the patient, and she had the JP drain, a PCA pump, slumped in bed. We already talked about that, but I just wanted to address it. And now we're going to move on to cough assessment. And for this, I'm just going to have the patient hold on to this pillow. Just with the JP drain, I want to make sure that she feels comfortable to cough. And I just would like you to do a nice good cough, get up anything in your lungs. I might expect it to be weak. The patient did recently have the surgery, so it might be weak, and I don't expect there to be sputum production. For palpation part of this examination, I'm going to put my hands on the different parts of her chest wall to see how it is expanding. First, I'm going to go to the upper lobe. And you take a big deep breath for me. And then come to the lower one. All right, take a big deep breath. Great. And now the posterior lower lobe. Okay. And since we're here, I'm going to do mediate percussion. With that chest wall expansion, I might notice decreased chest wall expansion because it might already be hyperinflated with the obstructive disease. So, yeah, and now with mediate percussion, I might expect some hyperresonance or tympanic sounds. Now I'd like to do an activity evaluation of the patient. I have her sitting at the edge of the bed, and I'm going to assess her sit to stand with the pain in the bilateral knees. I thought this would be a good way to test her dyspnea. She's been having short of breath with minimal exertion, so I think starting it with the edge of the bed would be a good place to start. So I'm just going to stand in front of the patient and guard a little bit just in case, and I'm going to have you stand. Yep, you can push off with your hands. Feet are flat on the ground, and stand. Good. Slow and control, put your one hand back, and we'll go sit back down. Good. All right, so patient is short of breath. She can only do one sit to stand. Is that causing you any pain?
A little bit in my knees.
A little bit in your knees on a scale of 0 to 10, 10 being the worst.
5.
A 5. So prior to, or the abdominal pain was a 4 out of 10. Did that change your abdominal pain at all?
No, it's about the same.
Okay. All right, to assess this patient's function, she definitely is showing decreased weakness in all of her extremities. I noticed that with the MSK screen, and I tested her lower extremity functional strength with the sit to stand. With bed mobility, I didn't show that, but I would expect that to be weak as well, just because of the dyspnea or shortness of breath and the weakness, especially in her arthritic knees. And then, and now I'm going to tell the patient about what I found today. Okay. All right, patient. So we found today that you're having decreased strength in your ability to move in bed, and then when we came up to standing, you definitely got short of breath, and that's to be expected with everything that's going on. And so with therapy, we'll increase your strength, we'll increase your endurance so that you can go back home. And with your knees, we can help with the pain in that by increasing strength and increasing your ability to move your knees, and yeah, hopefully get you home quicker.